Good afternoon, everyone. Welcome to this town hall, which is being co-hosted by the Perinatal Neonatal Quality Improvement Network and the Betsy Lehman Center for Patient Safety. This is Barbara Fain. I'm the Executive Director of the Betsy Lehman Center, which is a non-regulatory Massachusetts state agency that does research and convening on healthcare safety. We're really pleased to be partnering with PinQuin on the second of what will be a series of weekly virtual forums for exchanging timely information about COVID-19 and pregnancy care. In a moment, I'm going to turn this over to Audra Meadows, who, along with Ron Iverson, co-chairs the Massachusetts Perinatal Quality Collaborative. And Audra's going to explain today's agenda and how you will be participating in it. But first, just a few housekeeping items. Today's town hall is going to run 1.5 hours. We are planning to switch to a 1-hour format starting next week, but we just had too much important content to make that work for today. If you are having technical issues, you can send a chat to Alex Zhang, that's Z-H-A-N-G, and she'll reach out to you separately and help you out. Also, just a reminder that this meeting is being recorded, and that includes the chats. So if you have any concerns about the recording, you can send a chat to the Betsy Lehman Center. That's Sam Bissell, but it's showing up she's showing up as Betsy Lehman Center. Audra, I am going to now turn this over to you.
Thank you, everyone. Again, we are thrilled to have you join us as we continue to have virtual town halls and discuss this rapidly evolving issue of pregnancy in response to COVID-19. This pandemic, as it continues and the policies continue to be generated and the work continues to develop, we are thrilled to continue to bring topical information to you to help you in your local institutions also adopt new policies and procedures to help aid women as we continue to work with them in pregnancy and during this pandemic. So you will hear today from Dr. Allison Bryant. You will hear from Tina at Lowell General Hospital, Dr. Moore Simus from UMass Memorial Healthcare, Christina Gable and Lorenzo Holt from company Doula Care, and Dr. Lena Mittal from Brigham Women's Hospital as we talk about issues related to what's happening on our labor floors and our outpatient centers. Tina, I am very sorry. You're going to say your last name for everyone, so I apologize that I looked at it and did not practice it today, so my apologies. Then we'll moderate question and answer at the very end. This town hall will be 90 minutes, and you'll hear the speakers speak and then introduce each other as they move forward. And we get to the question and answer portion. If you can continue to chat your questions into the chat box, we'll have them ready for the question and answer portion at the very end. Next slide. For those of you who are not very well aware of PinQuin, our state perinatal quality collaborative, we are an active data sharing organization for quality improvement, continuous quality improvement. And PinQuin works to achieve measurable improvements in perinatal healthcare and outcomes while reducing health disparities and achieving health equity. And with that, we focus on moms, babies, newborns, and families across the life course. So with that, you'll hear from some of the participants today or the speakers on how their organizations or how they themselves have incorporated the concepts of quality, continuous quality improvement, equity, and data or sharing of information in the work that they've done. So with that said, with no further ado, I'd like to introduce my colleague, Dr. Allison Bryant Manza, maternal fetal medicine specialist at Massachusetts General Hospital, to speak to us about equity in the time of COVID.
Great, thank you, Dr. Meadows. So I'm really pleased to have been able to chat with you guys all about thinking about obstetric equity at this really challenging time. And I'm really pleased to be on a panel with such esteemed colleagues. I really also appreciate the work of PinQuin and the Betsy Lehman Center for really putting equity up front, and that's really where I think that we all feel like it should be. So next slide. As those of you who've heard me talk about equity before know that I oftentimes lead with this slide to really think about where health and healthcare inequities come from. And so I'll repeat it here because I think it's important to ground us. So yes, there is some role for the patient level factors in terms of contributing to some inequities in terms of particular beliefs and preferences, perhaps the role of culture. We as providers have a lot to play with how inequities play out in the medical system in terms of our implicit biases, our own knowledge and understanding. All of that comes together at the level of the clinical encounter and then really is encapsulated in the greater healthcare system. So how we finance healthcare, how we deliver healthcare, how we think even about quality metrics all sort of contributes to inequities. But what I didn't love about this rubric so much is what I thought that was missing was really the structural factors. So next slide or next. I think it's just really important for all of us to really understand the structural factors that really contribute to healthcare inequities. And I think if drawn to scale, next, you can hit it again. If you just advance one more time. Sorry, thank you. It's just, if we're really drawn to scale, the structural factors, I think, really sort of overwhelm all the others in terms of thinking about social determinants of health like poverty and wealth, stability of housing, food security, and racism. And I think particularly in the COVID epidemic, these are really so very central to what's been going on. And it's, you know, as we listen to the stories out of Wuhan and out of Italy, we weren't hearing a lot about inequity, but it's no surprise, I think, that as COVID came to the American shores, that we would see this play out in the way that we have. Because really, though COVID-19 is an infectious disease, it is also very much a social disease. So next slide. I think it's also important to ground us in this conversation about thinking about really, you know, we'll talk a lot about social determinants of health, both in what my presentation and what you'll hear from others, and that social determinants of health for sure influence health outcomes. But in addition, I think we need to be mindful of where those social determinants come from, and that they really are sort of grounded in structural racism and institutional racism that have led to many of these social determinants, so things like neighborhood segregation or differential healthcare access or housing instability. And so I think that that's just really important for us all to keep in mind. And so if you click one more ahead, I think if we think about sort of COVID in particular, we've talked a lot about in the clinical setting how there are clinical conditions like hypertension, diabetes, chronic conditions like obesity, which worsen the likelihood of severe respiratory illness among people, and that we know that all of those are contributed to by social determinants of health. But I think, again, it's really important to consider that the risk factor for all of these things and differential outcomes really is racism and not race. So if you click forward one more time. So if we want to think about sort of defining the problem, what really is the problem in the time of COVID? And so what I think that we are all sort of witnessing and seeing firsthand is that there's an inequity in the burden of the disease and also in terms of the consequences. So in particular, who have particular living arrangements, so if they have marginal housing or working circumstances, so working in industries that were not able to close or having no access to sick pay, so showing up symptomatic to work, has made these principles of social distancing and in-home isolation very challenging. If we think back to the beginning of the epidemic and all the public health messaging that we heard, you know, sneeze into your elbow or use hand sanitizer, or don't hug people, or wear a mask or don't wear a mask. Many of those are delivered in English and not necessarily delivered in a multilingual way, although we are catching up with that regard. We certainly know that access to testing was not uniform by population, and that one thing that's really worrisome to us is that the prevention mechanisms, so namely home confinement, really has increased the risk for gender-based violence among many populations, including some of our most vulnerable. We've seen racist and xenophobic attitudes that have shown themselves to be a threat to both patients and our workforce. And then, as we already mentioned, those comorbid conditions that are risk factors for severe COVID illness are differentially distributed in the United States, and they are, you know, have their legacies and long inequities and structural racism. And this is all sort of in the backdrop of what we already knew, and this is a typo, so I will change this on the slides that get sent to you, but the backdrop of the maternal mortality and severe maternal morbidity crisis in the United States, particularly. And so I think it's worth sort of saying out loud that this is in fact Black Maternal Health Week, and telling and helpful that we're having this conversation today. Slide, please. So I think if we think about the threats to equity in the COVID pandemic and what we should be doing at the institutional level, these are the domains that we at MGH focus on. And I was asked to speak a little bit about how we can sort of apply an equity lens. And I think the things that are most important to be intentional, and it needs to be upfront. So I think that we were very lucky at MGH department that we already have structures in place to think about equity at every level at which community health is delivered. So at the hospital level, there is now an equity in COVID task force that's born out of the equity work that was already being done at the hospital level. And similarly, we have a departmental equity in COVID working group that works on some of these issues. Next slide. And I think what's important for us, what I should say up front, is that we are very challenged at MGH in that the communities that we care for are some that have been most hardest hit. I think everyone has that experience across the state, but in particular, we are sort of very mindful of what's happening in Chelsea. So MGH Chelsea is about 5 miles from MGH. A large number of our patients who deliver at our hospital come out of our MGH Health Center, which is an amazing freestanding health center that is largely one-stop shopping for much of the outpatient care. But as we're learning over the past week or so, Chelsea has really emerged as sort of a hotspot for COVID-19 with rates of infection, at least from testing that we know of, that's almost 2 to 3 times higher than the general population in Massachusetts. Next slide. So this, which you're not meant to be able to read, is sort of our departmental equity plan for COVID. And it's really broken up into those domains that I sort of presented on the last slide, and we will revisit. Basically, at this point, an 8-page living document that we add to every week on our institutional equity calls to sort of brainstorm those ideas that in progress, things we should be thinking of, things that we take off the list. And so I just recommend for all of you who are doing this work, really very much an iterative process. We are trying things, we're taking them away, we're pushing for it. And so just next slide, just 2 examples of those. So if we think about clinical care, you'll hear from others on the call a little bit about the challenges of telehealth. So we certainly knew from before this that many of our populations would have differential access to telehealth. I'm super proud that our institution sort of recognized as they were thinking about what they were going to create as the institutional platform for telehealth. They were moving in one direction with a platform that would be quite easy for providers to use, but ultimately was not going to allow for a third party or a medical interpreter to be easily integrated. And so switched gears across the institution to support a different platform so that we could make sure that we had equity across our institution. We are providing donated blood pressure cuffs to women who are not able to afford them, mostly from philanthropic donations. In terms of community health and engagement, what we certainly know is that we've always been screening for social determinants of health in pregnancy, but we know that if we screen in the beginning of the pregnancy, that same woman who wasn't food insecure at the beginning of pregnancy may certainly be insecure by the end. And so we're trying to screen early and often and sort of provide enough resources in their communities. I think the issue of social reproductive justice is one that's really quite important for us because reproductive justice often gets trampled in times of crisis. And so we are being very mindful of making sure that women have contraceptive access who want it, who have access to removal if they don't want it, and thinking about things like tubal ligation on our labor and delivery units, particularly for women who may not have financial access once this crisis is done. In terms of bias and mistrust, really have put that front and center and always have in our institution, but really recognizing that in times people's biases really start to show themselves. So asking our providers to be very mindful of. We have been collecting data on inequity in COVID in terms of access to testing as well as in COVID outcomes, and are creating heat maps in terms of zip codes about where our most active women are coming from, and they really are coming from predominant zip codes in Chelsea, Revere, and Everett. The last 2 things I will say is just as a tertiary care hospital, we tend to do a lot of research, and there's a lot of research coming up in the sort of COVID epidemic. And what we want to be very sure of is that we are representing adequately those women who are most affected by the epidemic. So really making sure that we have bilingual recruiters so that we can really capture those women's experiences. And then lastly, in terms of philanthropy, we've all seen on social media and other places, people who very much in the public want to do things for healthcare workers, which I think is important. And it's nice certainly to have that platter of food that shows up on. But really the people who are oftentimes are people who are not living on the margins, and so we want to be very mindful of who within the institution sort of benefits some of those philanthropic efforts. So those are some of the things that we are doing. I'm happy to take some questions later in the Q&A session. We're going to hold questions to the end, but for now I'm going to turn it over the presentation to Erin Solmy from Lowell General, who's going to present on COVID positive dyads.
Okay. Terrific. There we go. All right, everyone. Tina Ferenzolmi. I can say it better now.
Nice.
Take it away.
Okay, thank you, Dr. Amanda. And we're actually honored to share with the group from Lowell General Hospital kind of the impact of the mother-infant dyad and how we've actually been promoting bonding between mom and baby. We had to take a look at internally what our resource management was going to be specific to whether a baby was going to room in with the mom or not. With that, we utilized Zoom technology with the neonatologist or the pediatric provider to actually consult with the mother and support person prior to the delivery. We've been lucky enough that we've been able to do that with all 3 cases that we've had to current date. And out of those 2, we also had to include interpreter services. So whenever we're counseling a family regarding the recommendation to cohort or not to cohort, we went back to the AAP recommendations. And then we also had to take a big impact each one of these families that we've dealt with are immigrant families, and so we also had to incorporate our cultural expectations for these families as well. So a lot of the factors that came into play were, is this a well-appearing baby? Is this a sick mom? Is there a healthy caregiver present? Are there any language barriers? What is their plan for feeding their baby? And as well, how can we facilitate bonding if and when the mom and baby are separated? So we had some beautiful moments that we're able to talk about whenever in regards to that, where we also use Zoom technology to allow the mom and the support person to actually visualize the admission process if the baby was not in the room with the mother. The next thing that we go to, obviously, is discharge planning. So whenever we talk about health care and equity, we actually are dealing with families that may live in very multi-generational homes. They may be multiple people in a home. They may have one general meal sharing space. There may be other sick people in the home. These families may be also trying to care for their other children, whether they've been exposed or not. And some people actually had the capability of being in isolation. And then, of course, some of our families don't have that safe space to take a baby after discharge. So we've been collaborating with our COC department as well as community health within Lowell to make sure that we have a safe location for our babies to be discharged to. Next slide. So here at Lowell General, what we did, we kind of sat down as a group and said, how would this look for us? So we actually took the opportunity to develop an algorithm that kind of gives us some general guidance. It does not speak to every single occurrence that could happen, but it gives us a general framework to work within. So as we're looking at our mom, and once again, we want to be able to share this with people. If you feel like this would be helpful in your workplace, please let us know. We have been following AAP recommendations for cohorting or not cohorting. We're also following the American Breastfeeding Medicine recommendations for breastfeeding. So we do encourage breastfeeding whenever it's appropriate, and we also encourage express breast milk being given to the baby whenever appropriate as well. So with this, there are many different paths that we can take. We needed to talk about our internal resources that we had, and that includes who's actually going to be in the delivery and what the needs are, how many people we would have in the resuscitation if a newborn resuscitation was required. And then, of course, we want to maintain NRP standards by making sure that there's a nurse specific for the baby or an NRP provider for that. Once again, one of the consideration for the newborn is if the mother is under investigation or if she is actually positive or if we're in the rule-out period. So then the next step comes down to if the baby is well appearing, and then of course we're actually going to follow our newborn order set for those babies. We are consulting with ID at every step of the way to make sure that we're doing the appropriate testing at the appropriate times. Some of that has been dependent on if we have a mother, if we have a positive test on the mother, that has an impact on when we're doing the test on the baby. And if we are awaiting the actual testing on mother, there are times that we actually have put that off until we actually have the maternal testing back. Obviously, if the baby is not well appearing, we had to look at our internal resources as far as where we had negative pressure rooms and where we could continue to provide that care in the safest manner possible. So this may be different location to location, organization to organization. As we move through that process, we did say if the parent cohorts with the baby, we also recommended placing the baby in an isolette, not for temperature management, but as a physical barrier space as well, which may help if mom is symptomatic or, and then of course, if the caregiver or the support person is symptomatic, our recommendation is that they contact their PCP, be tested, and then we are making a determination of what that impact would be on the discharge in the home status as well. So every step of the way, we're actually huddling with our own group to say what's appropriate, when it's appropriate to transfer a baby, when it's appropriate to transfer a mother, and we want to make sure that we're being very mindful before we do that. Next slide. Okay. So just wanted to share our cases with the group as a whole because they were actually so very different. Our initial family, actually, it was a family that was here to go to school, so they were from another country. This is their first baby. Mom and dad, highly educated, so they'd actually done a lot of research before we actually spoke to them or began the counseling session. So as we began our Zoom discussion with the mother, the father actually stayed at home with another family member who was COVID positive. Mom was tested. Mom was COVID positive. So it was determined that she was full term and we would have her here at the hospital to have a more controlled induction process. With that, we had obviously a little bit more time, a few more resources with us to kind of take a look at what we were actually doing. And probably about 2 seconds into the conversation about the AAP guidelines, the mother said, "I want to stop you now." The father of the baby and myself, we've already discussed, we don't want to risk any potential exposure to our baby, so we're asking to be separated from our baby at time of delivery. I have to say that kind of took us back a few steps because we wanted to make sure that we had the opportunity to talk about what that actually meant for them and what that separation would mean during the hospitalization, that there would not be a reunification because we knew mom was positive and would probably be discharged before the baby. So with that, we began talking about that separation and that we wanted her to pump so we could give her baby breast milk. And literally in the same breath, she said, if there's any risk that I didn't clean my pump properly and I might expose my baby, I would rather use formula. So I think we kind of took another step back, thinking all of the things that we were going to recommend, and this family had already researched ahead of time. So as we move through the process, once again, they live in a very small apartment. They have limited resources, and we just wanted to make sure that we were giving them every support that we possibly could. So with that, obviously, there's the one-on-one education with this mother. We did Zoom, almost like FaceTime, with her and her baby multiple times a day to make sure that they were connecting and that she was seeing the people who were actually providing care to her daughter. We had telephone lactation services that were calling and speaking with the mom frequently. We did end up testing the baby ×2, and both of those were negative. Precautions removed, and then the baby remains on pediatrics pending discharge to the healthy caregivers. Our next case was, once again, we had a very sick mother with respiratory symptoms, pneumonia, had not been tested, so once she came into the hospital, we did her COVID testing, actually expecting her to be positive. This was her third baby. The husband was with her, and once again, he was having to go back and forth to take care of other children, as well as having exposure to other people in the home. So as we move through that, this family, after counseling, said, we know that there's not a healthy partner at this point, and asked to be separated from the baby. The healthy partner then decided to stay with mom, not knowing what his exposure had been. Once again, using Zoom calls with the parents frequently, as well as interpreter services, and they had formula fed their previous 2 children and had a plan to already formula feed this child. This mom actually got tested. Her first test came back negative, and we thought that she was so symptomatic, we weren't sure if we had gotten a false negative, so was retested a second time within 24 hours. The second test came back negative. Mom was being treated for her pneumonia and actually was improving. So whenever we got the second negative back on mom, we actually moved her down to the mother infant unit, and she was reunited with her baby and went home in a perfect little scenario. Even though the start was a little rocky, we actually had a lovely closure from a discharge support for this family. Our next case that we had is positive but asymptomatic. Mom asymptomatic, as well as her husband, or the healthy caregiver, was also asymptomatic. They do have a second child that a family member is self-isolating with. This family, however, lives in a multi-generational home and shares a living space as far as their kitchen, meal prep, and bathroom with 2 other COVID-positive patients. So with this, even though Mom and Dad that were here in the hospital are completely asymptomatic, and at this point, Dad was not tested, and we do not know Dad's status. This was their second baby, and they both decided that they wanted to keep the baby in the room and cohort with them. So we placed the baby in the isolette, once again, not for temp management, but just as a physical barrier, and she stayed in the mom's room, and the father, actually as the healthy caregiver, did the majority of the infant care. But it allowed us the opportunity to have our interpreter services in with the nurse and do all of the infant and maternal teaching. And then, of course, we're working with our Department of Health here in Lowell to actually ensure that there's a safe discharge plan for this baby to go home with the parents. Next slide. So with us, we talk about our lessons learned, and so after each case, what we decided to do was to debrief. We're realizing as we go into each one of these that there's not a one-size-fits-all approach to this, and we are having to make a lot of case-by-case decisions, even though we have a framework defined. Bonding, obviously, whenever we have our parents stay with the baby, that helps to remove one of those barriers. Otherwise, we've been using Zoom technology and making sure that we're also being very sensitive to the cultural barriers that we may have with the families that are involved. Discharge planning, obviously, this is a big effort that comes not only from our inpatient status, but our continuity of care and also our community providers as well. Information sharing, obviously we are doing this phone call, as well as we're tracking each one of these cases and working through lessons learned. Thank you so much for your time, and I would love to go ahead and introduce Dr. Tiffany Moore-Simas.
Hi, good afternoon, everybody. Hi, thank you for the opportunity to talk about what we have been doing around maternity center visitation policies here at UMass, and really our efforts have extended more regionally. Next slide. So as most of us are well aware, hospitals across the nation are limiting visitors to decrease exposure and virus transmission to patients, and even more so to healthcare providers trying to preserve the workforce. Often exceptions are given to maternity centers or birthing centers and our pediatric units. It became clear very early on as our caregivers' anxieties were rising that despite us always thinking ourselves as being very family friendly and very family focused, that there was some initial urgings really to limit the visitor policy from within our caregivers, within our maternity center, which I found surprising. I expected the pressures to come from external to us, but they were coming internal. Next slide. We had to go back and just, remind people that there was guidance, through our national organizations and locally from the CDC, from ACOG, and Mass Department of Public Health, that it's not that anybody was saying there cannot be visitors in the maternity center, but there are reasonable guidance and restrictions around this. So the CDC guidance is in the document, considerations for inpatient obstetric healthcare settings. We read this over and over again. There was, a suggestion to limit visitors to pregnant women who have known or suspected COVID-19 positive disease too, but that limitation was essential for well-being and care. We need to think about well-being and care, that, limit to one essential or consistent person. Think about, if you aren't in fact allowing face-to-face time, at the bedside visitation, then think about using video, virtual, or other types of support. Of course, guidance around screening for visitors and not allowing non-healthy persons to enter, masking according to current facility policies, and then limiting visitation to the patient or mother's room and not any other areas of the facility like the nursery in particular. The American College of OBGYN really, gave leeway to say that the visitation policies should be made at an individual facility level and based on community spread. And when we were first talking about this, we did not have a high prevalence. We were not seeing much in the way of positivity or even persons under investigation on our units, and also ACOG deferred to local and state recommendations. They did suggest reducing to a minimum, and then of course referred back to the CDC guidelines. And then from a mass DPH perspective, the guidance was around screening visitors and restricting visitation as necessary to protect the health of patients and staff. Maternity center was not specifically mentioned. Next slide. As we had our visitation policies in place and ready to go, everybody was as comfortable as anybody was going to be with them, a couple of things happened simultaneously that really made us aware of what we were doing and how that may or may not influence others. So the very concrete example is that Thursday, about 2 weeks ago, we had just finished up our policy, and somebody came running into my office and said, "What happened at X hospital?" And I'm like, "What do you mean?" They said, "We literally, in the course of an hour, got a request for transfer of patients, 6 patients in an hour, from X hospital." And I said, "Oh, that's interesting." So we reached out to them to find out what happened. And what happened was that they had made public that they were not going to allow support persons in cesarean deliveries. And we said, "Oh, that's interesting." And then in the next hour or so, I got a number of emails from private community docs that are federally qualified health centers emailing saying, "Are you getting a lot of requests for women who were previously in New York to deliver here?" And again, in that next hour, we had gone from, we had approximately 8 additional people from New York that were looking to have their care performed here. And so in the course of 2 hours, we suddenly had a transfer of 14 people that we were aware of in very short order. And we said, okay, things are changing. And then within the next, I want to say about 24 hours, I received a call from the head of our GME, our Graduate Medical Education Department, saying that there was a strong coalition of pregnant women who were married to or had significant others who were healthcare workers and were really wanting to understand whether or not their partners would or would not be allowed into the delivery. And we said, okay, we thought our visitation policies were in play, but it looks like we need to think about them a little bit more deeply and really think about, beyond a general policy, really what are very specifics and individual populations we need to think about. Next slide. With regards to the area hospital, what we did was, at UMass Memorial Healthcare, we have approximately 6 maternity centers that refer into our hospital as a tertiary care center. And then the hospital that we received calls from for their patients transferring care when they had altered their policy was to the west of us, and they also have another 4 hospitals or so that refer into them. And so we quickly realized that with this movement of patients, that was not in the patient's best interest. To really, continuity of care is what we were, what is often desired and what we seek to achieve, nor was it in the providers or the hospital system's best interest. As we were all in the process of surge planning, we were really surge planning around COVID, not necessarily surge planning around a change of delivery volume. And so we very quickly formed an alliance of these maternity centers to discuss initially the visitation policies. As it became clear what one did affected the other. It has continued on really because people have found comfort in being able to share approaches and policies. We did it initially sort of central and western Mass because that was the immediate need, although we can certainly argue, and as we've had some people refer from Boston, that we really should expand this across the state. Next slide. As we were, as we were preparing for this alliance, we wanted to understand what other maternity centers' visitation policies were, and we've continued to meet over these past weeks, and this is the most recent survey. And at least at the moment, every one of the maternity centers in central and western Massachusetts are allowing labor support persons for asymptomatic women at vaginal deliveries and at scheduled or non-emergent cesarean deliveries. The majority, for vaginal deliveries to women who are persons under investigation, a support person is still allowed 100% at all of them. That does go down in the cesarean deliveries, and we do see, again, a change for COVID-positive women, the facilities not allowing a person at the bedside, but virtual support being advocated in these situations. Next slide. The question around can persons from high prevalence areas have a labor support person came up, and it really was a question that came from our institutions, because the institutions were feeling like our quote-unquote lax visitation policies were what were driving women to seek our institutions out in particular, and they were not thrilled with that. As the community prevalence has changed, as our own rates have gone up in the area, this has become less of a topic of conversation. But what we really needed our institution to realize is that it's not that they were seeking us out in our visitation policies per se. What these women who had a choice and who had options to potentially, shelter elsewhere were being, asked by family and friends if they wanted to come live with them or come, leave the New York area and come here. And so, what we needed our institution to realize is not that these women were, at the time were, in New York and calling to see if they could start care here. They were here and had been in many cases purposely self-quarantining for 2 weeks or more. And so they were going to deliver here, whether we said yes or no. So we finally got the institution to realize, it is in our best interest to meet them, provide care, know that they're coming, and have a relationship in advance. Next slide. Regarding the screening of support persons and amenities for support persons, universally all the institutions are requiring that support persons be healthy, and so that if they are screen positive, that they're not allowed to sort of enter through the lobby. 80% of the institutions are masking the patient and the partner, at least as of last week. It wasn't 100%. The initial screening questions that are being done in our hospital lobbies include symptoms for everybody. For the majority, there are still questions about travel, and for the majority, there are questions around exposure to COVID-positive persons. Beyond that initial screening, 80% of our facilities are doing a temperature screening throughout the stay, so 1 to 2 times a day on, labor day 1, postpartum day 1, postpartum day 2. And 100% are not allowing support persons to stay if they, have an elevated temperature or are experiencing new onset of symptoms. And so in that case, we would transition over to virtual support. 60% of the facilities have said that the support person cannot go in and out of the hospital, and for those that said that haven't done that, they still are putting restrictions on it or saying it's highly encouraged if it is not required. There's been a lot of conversation around extended, postpartum stays that are complicated or antepartum stays, and most of our units do allow for a case-by-case conversation around, if somebody needs to go home, can they or can they not come back, and being able to, either step that up to our command center or the leadership within the maternity centers. What we did identify early on is that often people leave because, of course, they need to eat. And prior to the pandemic, I don't know about your institutions, but ours did not allow the support person to, order a tray. Really, trays and food were for, for the patient or the mother, and that the support person needed to, procure their own supplies or sustenance. And now 100% of us are providing meals for the support person so that we are able to encourage this, rooming in and staying with mom and being present as a support person. Various institutions are working through IT for virtual support, and what that looks like is different in institutions. Next slide. So one of the things that we realized is, the exposure to COVID-positive persons. The question came up in the context of, women who are pregnant and married to healthcare workers, which is, a privileged population of persons. But also, if you think about a lot of the essential workers that are out there, they're not healthcare workers, but they are essential persons and have potential to be exposed. So what we did in this case is we have separated. This is specific to UMass. We've created an area in our lobby where pregnant women are brought over to the side because more often than not, they're coming in healthy for delivery and sort of trying to kind of separate away from those that are coming in with potential, symptoms and seeking medical care for that reason. And then as part of the pregnancy-specific line, if they answer the question around exposure to COVID-positive persons, there is subsequent questions around, was this exposure in the line of work, and were you wearing PPE to help increase the number of persons that would be at the delivery? It was deemed unacceptable that if our, for example, health cleaning staff was able to be in the hospital to help clean, but then was not going to be allowed at the delivery, and same thing with our healthcare workers. So we, deemed that unacceptable and transitioned from there. Additionally, for women who were known to be COVID positive in pregnancy, let's say at 32 weeks, 33 weeks, or what have you, we created a ambulatory COVID cohorting clinic so that we could really, consolidate the care there, and a significant focus of that care is providing testing so that we can, quote unquote, clear them of the disease so that they themselves and their partners are able to come in and have what would be a, quote unquote, usual pre-pandemic experience so that everybody is able to be at the delivery. Next slide. So some of the lessons learned, very quickly realized what one of our facilities does, it affects the others. And so this alliance across the state, became very important, and arguably we should expand that across the full state. Regional alignment and information sharing promotes continuity of care and support for our maternity centers. There's really been an appreciation of us having this ability to share and talk with each other in a structured way. It's important to address special circumstances. Think about the healthy pregnant women at the hospital entrance separate from those that are coming from other types of medical care, and think about our frontline essential care workers. Some of the barriers we needed to address were meals and not relying on patient technology for access for virtual support, because there can be, of course, a real differential around what type of technology people have access to, what hours, data usage time, et cetera. We wanted to be able to overcome all of that. And then communication and centralized documentation is essential. We did, from the beginning, create visitation, documents around how your prenatal care may change in the course of the pandemic, how to reach our services, what visitation policies would look like in our maternity center, and we made sure those all from the very beginning were translated into numerous languages, and those sit in a centralized location so that all persons, all providers who deliver here and patients are able to access them. We do hand them out in paper and provide them through our MyChart system. And then obviously this is a topic that will need to be iteratively revisited over and over again as the pandemic continues to evolve. So with that, we'll hold on questions until we get it to the end, and now I will turn the presentation over to Christina Gable and Lorenza Holt of the company Doula Care, who will present on centering patient voices and doula concerns in policy.
Great, thank you so much. And I just want to thank everybody for including us in this conversation. We really appreciate the invitation to be here. Next slide, please. So we work with a company, Doula Care, and you can learn more about us on our website, which will be available at the end of the slides. And I want to say that we would like to focus on our time on specifically how providers, oh, I think we're getting some echo, on specifically how providers can work with doulas in this time. So some of the concerns that we're hearing is, from parents who are saying, I'm worried about not having my partner or doula with me during labor. That seems to be a primary concern. And the ways that the providers can partner with us on this is by using FaceTime with the doula during labor for virtual support. So just like they might be FaceTiming with their partner, doulas are really transitioning to FaceTime support too, if that's what the circumstances allow. And then moms at risk of delivering alone could have a doula with them, especially in hospitals and institutions who allow, you know, a well support person into that time. Next slide. Another primary concern we're hearing is I'm worried I will be separated from my baby after birth. And this really goes into a lot of what we've been talking about on these calls, which is so practically useful for us as doulas, and I'm sure for everyone else on the phone. The way that we can partner here is by sharing information like this about what the changing policies and practices are at various hospitals. And we invite providers to keep us abreast of those changes. I know that it's quite a lot to keep on top of, and it changes every day. But to the extent that we can push information out into the community, especially through doulas, we can help birthing parents understand their options during COVID-19. And that's really a role that we can play on an education level prenatally. And then in light of those changes, we can also help them develop a birth plan. So birth plans are something that we routinely go through with our clients, and we always ask about differing, you know, policies and availabilities at different hospitals. You know, might you have access to this, or is the room set up like that? So in light of COVID-19, the more information that we can work together and share, the better our birth planning can go. Next slide, please. A third concern we hear often is I'm worried I won't have my support network around me when we come home. And this one is particularly hard because the postpartum period is so crucial and can be so hard when you don't have any support around you in general, but especially now, even for those that do have supportive communities or family members, those family members and neighbors and so on are having to be distanced from them for very good reason. So we would like to invite providers to partner with doulas basically by, you know, telling doulas and doulas helping providers also understand some of the community resources that exist so that we can have a free-flowing exchange of information about added resources that families can have in the postpartum period. We also do regularly check in with our clients, and that's kind of an additional check-in in conjunction with what the healthcare system might offer. So just know that we are checking in, and it would be great to have those lines of communication open again, because we can basically alert providers when a parent is particularly struggling or showing signs of depression. And I know Lena is going to talk about mental health very shortly here, but I know mental health has really been stressed, especially right now. Next slide. And we wanted to, you know, also include a concern of providers, because really it is about all of us and all the concerns. So just some ways that we want to offer that you might be able to do that is asking the patient if they plan to have a doula with them, and if they're willing to share that contact information with you, just so it's something that could maybe, you know, be on file in the chart, or, you know, something that you have access to if you want to start communications or share resources. Keeping communication about emergency policies flowing to the doulas so we can educate clients prenatally. Again, I kind of talked about that earlier. And then working with doulas to address language barriers while in the hospital. So at a company, Doula Care, we're really proud that our doulas speak 10 plus languages. And we're really proud of the linguistic diversity we have within our group. And I think it's really crucial at a time right now. Someone mentioned earlier, I think it was Dr. Bryant Mantha, that some of these, you know, some of this information is not being translated to multiple languages. And I want to offer to help to lean on doulas in playing that role, because As policies and things are changing within birthing hospitals and institutions, doulas who may speak the language of the family primarily can help translate those changes. Next slide, please. And then we also, as an organization, just like many healthcare institutions, have had to really pivot and think about how we can support our doulas. We can't stress enough that supportive people also need support. And I think supportive people includes everybody here on the phone. So some things that we've done to prepare our doulas and adapt to these changing times is that we've created guides and tip sheets on how to conduct our normal prenatal visits with clients and how to do that virtually and what's best to cover during those visits. And again, that's where education and information about emergency policies would fit in really well. Best practices for traveling to and from the hospital so as to not put family members or self at risk. We are honoring every doula's decision as to whether or not she feels comfortable continuing to support clients in person, but those that continue to support clients in person, we, like many healthcare workers here on the phone, have had to kind of come up with research, I shouldn't say come up with, but research and disseminate best practices on how to enter back into our homes after having gone to the hospital. So that's something that we kind of pushed out to our doulas really quickly to keep them safe. Again, I talked about communicating emerging policies at various birthing hospitals. The technology piece, so I do want to say, especially since we're on this call talking about equity, that we serve mostly moms who are in accountable care organizations and are on Mass Health. And those are very diverse families within the Commonwealth. But also our doulas are very diverse, and that was a very intentional decision on our part. So while we think about, some of the families here in Massachusetts maybe having some barriers to kind of telehealth or some of these virtual technologies, we also want to hold in those concerns our doulas and our supportive persons within communities who may have, varying comfort levels with adapting to virtual technologies. So we've provided tip sheets, mentoring, and Q&A on how to do that during our monthly meetings. And then finally, I can't stress this enough, we need to emotionally support the people who are supporting. So we've done a lot to emotionally support our doulas so they can best serve their clients. Next slide. And I'll end with this kind of thesis that we hope folks can glean from our presentation, and then Lorenza can chime in, who's also with me here on the phone. And that is, when integrated into the healthcare team, doulas can help communicate the needs of the family and providers during a time of intense change and uncertainty. And with that, I just want to say this is a very open and welcome invitation to please use us in whatever ways are helpful, and we are happy and willing to do so. So with that, I'll kick it over to Lorenza, and then we'll move forward. And these are our contact information.
Christina, I just want to say, can you hear me?
Yes, we can hear you.
I just want to say you did a great job. You said everything that I would have wanted to say. So really, I don't have anything else to add other than we meet clients prenatally where we can be with them in labor, either virtually or in person in postpartum. And so to provide that continuity of care, I think, is something that we offer that is unique to doula care.
Thank you so much for having me. I'm Lena Mattel. I'm the chief of the Division of Women's Mental Health at the Brigham and Women's Hospital, and also the associate medical director for MCPAP for Moms. Next slide, please. So, I wanted to take this opportunity really as last week's virtual town hall was just so impressive, and so much important work has gone into the sort of development of preparedness and then response to the COVID-19 pandemic. And I think that given all that work, I think it's not unreasonable that mental health, is one of the things that we're sort of addressing in phase 2 of our response to to the pandemic. But MCPAP for Moms, for those of you who aren't necessarily familiar with MCPAP for Moms, we're a statewide program supporting obstetric providers, primarily obstetric providers, in addressing mental health and substance use issues in their patients. So really over time, especially over the past couple of years, we've really expanded to be as available to a wide variety of providers as possible. We have been around with our phones on since 2014, and our sort of functionality has primarily been in a virtual or kind of telehealth capacity from the very beginning. We currently serve almost 80 to 85% of deliveries or practices or providers managing deliveries in our state, and so we continue to be available. Next slide, please. What we provide with MCPAP for Moms is a variety of services. One is educational services. Two is a consultation service, which is primarily telephone and some real-time patient evaluation consultation, but the telephone consultations are primarily provider to provider, and then ongoing resource and referral services. And in the context of the sort of pandemic response, we're really thinking a lot about how we were already quite well poised to be able to transition our services to remote work for our team and really pivot along with the rest of the mental health workforce to providing virtual consultation, virtual services. And really we were quite pleased to be able to continue to essentially operate in the same capacity that we have always been able to operate in. If anything, many of our partners and many of our providers are providing a higher volume of services in terms of mental health and telehealth services for mental health needs. Next slide. One of the most important parts of what MCPAP for Moms has always recommended during the course of obstetric care and during the course of the postpartum period has really been around screening for mental health and substance use during and after pregnancy, though the reality is that in the context of the changes in care that has been kind of rolling out and have been incredibly essential for safety for all, the recommended processes around screening are not possible. And so one of the things that we're learning in our role of consultants is that we're really spending a lot of time thinking about how do we detect and how do we address mental health symptoms or destabilization or new discovery of substance use disorders, for example, without being able to utilize our usual screening practices. And so we're often working with providers to think about how and whether measurement-based care may be possible. So some provider settings may still have the ability to use patient portals or patients' own devices for completing screening assessments or doing one-on-one questionnaires. But if not possible, then we're thinking a lot about how we can be providing consultation around mental health, how to be cueing providers who are calling us about new symptoms or understanding current symptoms or interpreting reports around mental health needs in the context of not being able to have the quantitative measures that we often recommend. So the Edinburgh Postnatal Depression Scale, the NIDA Quick Screen, the GAD-7 for anxiety, mood disorder questionnaire for bipolar risk. And so we're often faced with needing to sort of switch and change the way we're considering our consultation. A lot of what we're doing is counseling around perinatal mental health risks with this kind of new twist, with really thinking about what is the impact at all times of the increased level of stress, anxiety, trauma in the context of COVID-19. And so thinking about the risks of untreated symptoms of mood, anxiety, and substance use disorders alongside the risks of treatments and shifting treatment. Thinking about how the risk-benefit analysis may shift. So, I think in particular of a case in which we were consulting with an obstetric provider who was working with a young woman this was her first pregnancy, and she had really struggled with significant and relatively difficult to treat depression throughout her pregnancy, and had slowly over time become comfortable with using an antidepressant. And then in the context of the pandemic, really thinking about what her delivery experience could look like, had become very firm in her desire to have a home birth. and really thinking about how was the counseling around the use of her antidepressant, and making sure she had the right supports in place, that she was knowledgeable about what neonatal symptoms might look like in the context of an antidepressant, really shifted our discussion about the risk-benefit analysis around using an antidepressant for this particular patient. She had very, very severe depression, so we had to really think about how do we make sure she has everything that she needs. And we can think about this in a variety of ways, depending on the mental health condition and the course of treatment, but really trying to be thoughtful. What we're working really hard to do is, during the course of our consultations, be thinking about what would our usual risk-benefit analysis be around mental health treatment, and then how does that shift in the current climate? And then in particular, thinking about the impact for inequitable access to resources. And so very much what Allison spoke about in the very beginning, thinking about what are the both structural and social impacts on access to things like telehealth, access to things like resources like food and mental health engagement and family support and birth support, and the impacts that will have on our thinking about risk and benefit for mental health treatment. Next slide. So some of what we're really seeing and learning in the context of our consultations around mental health are really that alterations in pregnancy care do have a significant contribution to an increase in mental health symptoms. And then this is in counseling, as I was discussing, in particular to this one patient who had been thinking about home birth. Another thing that we're hearing quite a bit about are that patients are having a hard time thinking about presenting to hospital-based practices. They're perceiving a significant elevation in risk. Even though the number of visits has been significantly pared down, in-person visits have been pared down, the ones that are in person may be really, really difficult to present to for some women. We're seeing, the sort of over time, and I think we're really going to be seeing more and more of this as time goes on, the impact of the birth experience, the potential for trauma, the potential for isolation in the early postpartum period, the perception of loss of control and increased impact of fear on the emergence of trauma-related disorders as they emerge over time. Additionally, so number two, we're really noticing that women with pre-existing mental health and substance use conditions are particularly vulnerable to exacerbation right now. So as we're seeing, for example, women with mood disorders, women with significant depression or bipolar disorder, more risk, more a more than proportional increase in risk for exacerbation of symptoms. So the isolation that may come, the disruption in schedule and in routine can have a really significant impact on mood disorder. I had a woman tell me, and with regards to her substance use disorder, that the isolation, the purposeful social distancing that she was engaging in was very triggering around her recall of what it was like when she was not sober and when she was using substances more actively, and the purposeful social isolation that caused, and that she was feeling very triggered by the amount of alone time she was having and the very little in-person contact. And I thought that was really important to be thinking about, because for her, it was really important to be thinking about how do we flip the script a little bit and say this is intentional and this is in furtherance of her sobriety rather than instead of or at odds with her sobriety. When we're thinking about access to mental health care, there are real significant challenges in the context of thinking about inequity and structural racism and access to resources. And so one of the things that we're thinking about in particular with mental health is that mental health care often we have longer visits. So psychotherapy, for example, is often takes place in 45-minute or 1-hour visits. That can be really challenging if somebody doesn't have access to privacy or doesn't have sufficient access to data or a device that they can use or a space where they feel comfortable, or if they're not able to have that much time away from work, if they're not able to work from home or are continuing to have a schedule that doesn't permit attending appointments, or for many of the folks that we're seeing may even be working more in the context of this change. And so in particular, we're thinking about how do we increase peer supports, for example, or group supports that may be able to happen virtually, or not professionally led supports, like what can someone do on their own, or self-guided treatment in the context of this pandemic. Another thing that we're really kind of noticing in the context of our consultation is that the principles of trauma-informed care are particularly important and can be really helpful in both limiting, addressing mental health and wellness, but also limiting the negative impact that the changes in care can have. And so just to kind of review what trauma-informed care really looks like, it's really thinking about safety first, and sort of taking this approach of universal precautions around thinking about how do we emphasize a patient's autonomy, their ability to feel choice and trust in their care, where providers and patients are really in the position of being collaborators rather than a hierarchical kind of relationship. And then also a significant approach to care from the provider standpoint of empathy and humility around the patient's experience. And so as we're sort of thinking about how we can shift care and how we can optimize mental health outcomes, we really think about those principles, and in particular around trauma-informed care, with the idea that if we're practicing this in a universal way, that we can really be thoughtful about patients coming from all various experiences. It's also really important to know that the majority of ambulatory care in mental health has transitioned entirely to almost entirely to virtual platforms and telemedicine. But to the extent that it's needed, there still are options for inpatient psychiatric care, for higher levels of care that may still be virtual. For example, partial hospitalization or intensive outpatient programs are still happening. And then for those women who require urgent psychiatric consultation while in the hospital, there are psychiatric consultation services preserved in all settings. And so it's really important that while we're still talking about as much as we can, trying to limit exposure and trying to decrease the amount of physical engagement in high-risk situations, that when it's necessary, mental health care can still proceed at all levels of care. And then really thinking about how I think all of us, as we're transitioning into this kind of next phase of the response to this crisis, are really thinking about how intentional we need to be in terms of addressing mental health care going forward. I think as we're seeing the kind of phases and waves of what we have already experienced and what we will experience, there's going to be this entire next wave of mental health sequelae for our patients, for our colleagues, for those who have had increased exposure through their work, for those who survived COVID-19, for those who are bereft and experiencing grief in the context of having lost loved ones or colleagues or acquaintances. And so I think we're really thinking about, at MCPAP for Moms and as mental health care providers, how we're bracing ourselves to be available for the long haul and really kind of the marathon of the response going forward. Next slide. So right now, as we're kind of continuing to respond to what we're hearing and seeing is needed from providers and patients, we're working on creating materials. And so we have prepared a mental health care care package that's on our website. It's at mcpapformoms.org. You can find some COVID-19 resources, including a letter to providers, as well as this care package that has some nice resources, both for provider-facing and we're also working on creating some patient-facing materials. Our overarching organization, MCPAP, which is a pediatric program, has also created a similar mental health care package that has some parenting resources that we have found can be particularly helpful for our providers who are seeing women who are parenting older children while also pregnant or newly postpartum. We have existing on our website a toolkit for obstetrical providers specific to both mental health and substance use, and then we're also working on a toolkit specifically for substance use disorder providers, which is substance use disorder treatment providers, rather, that is coming soon. Next slide. And just as a way of reminding you how to access our consultation services, any provider can call our 855 number and engage with one of our research and referral specialists. And then that person, depending on what the needs are, can either determine if we can just help by sending resources directly to the provider calling versus having a provider-to-provider phone consultation. So again, it's all really constructed in a way to be as convenient to the person calling, so we can schedule the phone call back based on what works for you. And then we have traditionally called our direct patient consultations face-to-face, and that's not necessarily the case any longer. We're able to do virtual consultations, sometimes by video, sometimes by telephone. Really, it's based on the patient preference. And so it may still be face-to-face, but it may not be. But we're still able to do some phone consultation or some direct patient assessment and consultation. And then in addition, we can do some patient contact where our research and referral specialist is kind of engaging with patients and hand-holding through connecting to virtual mental health resources. So please do feel free to call McPlatform Moms. We continue to be available. And I'm happy to stay on for questions. I'm gonna, at this point, that's all the material I have, so I'm gonna pass over the baton to Ron Iverson for the question and answer session.
All right, thanks. Excellent presentations, thank you so much. I think that we're able to talk through some really interesting policies and algorithms and issues around equity. And I just wanted first to go, I thought the best way to do this would be to go through the presentations that we had and talk about, and just go through the questions that were put through, and then I have a couple questions to add myself. So we'll start with the first topic, which was considerations for equity lens on policy development. And I'm just wondering, how do you at Mass General get community input on equity issues in care? Dr. Bryant.
Hi, Ron. That's a great question. I think primarily what we have done is use our sort of community connections. So both talking to even community managers, folks at the town level. So I'm thinking particularly around Chelsea. So as the epidemic has become so severe in Chelsea, we've really done some outreach, both with community outreach workers that already work in our MGH Chelsea Center, who we sort of picked their brains a little bit about best ways to communicate with folks in the community because they've been doing this work for a long time, and then thinking about the institutions that exist in the community, talking to folks at the various food banks to understand sort of what sanitation and cleaning supplies do they have or do folks need, and there have been connections that have already been leveraged over the past decades that people have really started to use much more intentionally now as we think about this epidemic. And then obviously when our patients come in, we are sort of asking them what their needs are in a way that feels a little bit organic and letting them sort of guide us in terms of the things that they need.
That's great. Yeah, do you have specific meetings with them, or do you just wait for them to spontaneously present, or are they on any groups that you work with? Just again, trying to figure out how they have a place at the table.
It's a great question. I think that we don't have any particular community groups at this moment that we are talking to. So it really is sort of as patients roll in, we have been asking them questions when they are in front of us. I think that we have a great working relationship, again, with the community outreach workers, and those are folks who really are sort of side by side or 6 feet apart these days with us in the practices, so that when things come up from our committee, we can bounce them up. So our committee meets once a week, and we can kind of go back to the folks in the community or the community outreach workers and sort of bounce our various ideas off of them as a proxy for the community, which is not so great. But, we don't actually right now have a community group that we sort of call on in a regular way to ask questions about this particular epidemic, but we probably should.
Well, I mean, it still sounds great. I mean, it's much more intentional than a lot of us are able to do. So that's great. Another question was, what telehealth system do you use? And I guess more specifically, you had mentioned that it felt more friendly to patients, and I'm just wondering maybe like 1 or 2 hints on how we can make our telehealth sort of appropriate for patients of all backgrounds and races.
Yep. So I think it's a little bit of a work in progress. So I can say, I have no financial interest in any of the companies, but I think that I understand that There had initially been a plan to use Doxy.me, but the sort of default platform for Doxy.me had to be a one-to-one connection without the ability to build in a third person. And so, as I understand it, institution-wide, the plan is actually to use a Zoom platform, because then we can bring in a third person or bring in a video or a telephonic interpreter. So we really are getting rolling with that this week. So I can't even feel like I've done a couple of visits myself, and I think that patients are enjoying it. You know, I think most of our patients are young and somewhat tech-enabled and tech-savvy. You know, what I think I understand from some of our community health workers as well. And again, a lot of this is my parroting what's happening with our equity committee, who is doing lots and lots of this work together with me. But that sort of sometimes text messaging as a sort of first foray is more comfortable for certain folks, so to set things up by text messages instead of by phone, or certainly by our patient gateway, which is not so friendly and accessible to folks. But I honestly can't say that I have had a poor interaction with the video connection just yet, but we just are really getting that rolled out.
That's so interesting. Thank you. It'll be interesting to hear, you know, what you guys learned from that, because it makes sense. I'm going to just move along. It's already 1:20, and I know that people need to go places at 1:30, so I'm going to move on to the postpartum presentation and thinking about considerations for mother-baby bonding. Just a couple of questions that came from the outside from Britt. Will the slides of the mother-baby algorithm be available for this presentation? So the answer to that is yes. Lowell has mentioned that they're happy and willing to share. This whole presentation actually is going to be posted on both the PinQuin website as well as the Betsy Lehman website for everybody to view, and particular resources we'll be collecting on the PinQuin and Betsy Lehman websites for people to access as well. If you have algorithms that you want to send us, we would love to take them. Recognize that they'll need a date on them, please, and that they will be posted on the websites. Next question from BBS. How did Lowell do the newborn screens and hearing tests in the room? Tina, could you answer that, please?
Absolutely. That is a great question. That was one of the things that we began talking about very early on how we were going to operationalize that. And so for us, we went ahead and designated a specific equipment for our CCHD. Hearing screenings on the other, and then we're doing the newborn screen. We obviously can't take that newborn screen to the soiled utility room for the dry time, but so we are leaving it in the room and then processing it, handling it with gloves, making sure that we're handling it appropriately before we send out. For hearing screening specifically, whenever we've had the mom who came back negative, baby came back negative, then we went ahead and did the hearing screening. If this last one that we had, we still have a positive mom. She came in positive, so we're only about 3 days in, even though she's asymptomatic. We did do a screening or test on the baby. Baby's negative, but I think our consensus is that rather than risk bringing that hearing screening machine into the room with that baby, that with the positive mom, since they're cohorting, that we would do the hearing screening as an outpatient whenever we had 14 days post-positive test on mom. So we know that that will decrease that viral shed, hopefully within that time frame. And once again, we're kind of talking through all of those things with our ID group to make sure that we're doing it in a responsible way. But that baby will actually have an outpatient hearing screening, will not come back into the newborn nursery. We've actually designated a place in our patient care services. We'll take the hearing screening machine down and do a standard wipe down with our PDI wipes following the testing.
Wow, you really thought that through. Thanks. The next question is, whose devices did you use for the Zoom technology?
So we're very blessed that our organization and our leadership is committed to actually providing this service and decreasing the exposure of our colleagues. So we've been using Zoom. The organization actually bought multiple pairs of iPads. And so for internal use, if we have a patient that is a positive room, we're actually providing them with a Zoom device, which is an iPad in the room that's paired with a provider device. So we have that usually in our consultation rooms that we have with our providers, So if we need to do education with the family member rather than sending the nurse back in, if there's no hands-on duties, we're using Zoom. We used Zoom also for kind of that exposure so mom could see the admission process for the baby. We could also have them be able to visualize and watch as the baby was feeding or doing certain things. And we did a lot of our education, newborn education via Zoom from the off-site area if mom and baby are not cohorting. So it was actually our organization that committed to how we were going to do that, and they're doing that on all of the floors here at Lowell General.
Wow, you're lucky. You might get some follow-up questions from folks on that one. That sounds pretty great. From Dr. Meadows, Lowell General have a policy restricting the support person from moving in and out of the hospitals during the postpartum stay.
So this is probably one of our hottest topics, in all honesty. We are doing a lot of education with our families, obviously, talking to them about every time they leave that they are putting themselves at risk for exposure, but they're also returning that exposure to their loved ones. So we've done a lot of education with that, but we also know that there's sometimes that people have to. They have another child at home. They only have temporary child care. There are a lot of dynamics, and so we're trying to be as fair and as equitable considering their circumstances, and we're just taking it case by case, but we are strongly encouraging that whenever the support person comes in, they stay to reduce that risk of exposure to themselves, the mother, and the newborn.
That sounds like what a lot of people are doing. Thank you. With varying success. Sorry, go ahead.
And we are screening. So we screen, if you leave the organization or you leave the unit even to go down to Duncan, and honestly, we do a screening on them, and then we take a temperature 3 times a day on not only our patients, but also the support person. That way, if they became symptomatic while they were here, we would have an earlier identification.
Thank you. I'm going to move on. We only have a few minutes left to the visitor policies with equity by Dr. Morsimas. It says, this is a question from Katie, is it appropriate for each hospital to have a different visitation policy? Is there a role for the DPH here? Was there any overriding body, in addition to that question, around how these policies were made and rolled out?
So it's a great question around DPH. It was very clear in New York, like chaos was created when institutions were, kind of created their own policies, which was, a number of private hospitals had restricted visitors completely, and it became temporary when there was an executive order from the state that came down and said you must provide labor support persons. That was right around when we were looking at ours, and one of our colleagues had restricted, and then that's of course when we felt that with the transfers of care. My guess is precedent has been set that if hospitals were to restrict broadly, that the state may step in. Given that the restrictions, and changes in policies have had patients flow between institutions, there's potential for for the state to step in. But I think we're kind of now policing ourselves, for lack of a better word. I don't know that that's necessary. And I think to the best that we can work with ourselves, that's probably in our best interest. Certainly, if we were seeing, crisis care like they were seeing kind of in New York City across the state, I would imagine that, in fact, they would step in.
They will.
Yeah.
Next question to you, Tiffany, from Michelle Helgeson. Curious if any measures are in place in protecting healthy partner of COVID-positive patients, like a separate bathroom or shower.
Yeah, so I did read that in the chat box. We are one of the institutions that do not allow a healthy partner in for a known COVID-positive patient. The goal of that would be to continue to have a healthy partner able to provide, newborn care, to provide the express milk, etc. And so for our institution, it is we don't have them at the bedside. you know, I could imagine in our institution we do have a newborn in a separate room, so I could imagine a situation if there was a similar, if it was similar, that the partner could shower elsewhere. We do have partners and patients wearing masking, and so I do think if you're having a healthy partner at the bedside of a known COVID positive woman, I would certainly suggest there's some precautions that are in play.
Great, thank you. Now we're to doulas. From Britt Grappelberg, are there doulas available to come in if a support person for a woman whose partner is unable to be there if the patient has no previous relationship with the doulas?
Yeah, thank you for the question. So right now, most of the doula availability in Massachusetts for hospitals is through kind of already established relationships with various doula programs. I'm not currently aware, and others can correct me if I'm wrong, if there's a kind of centralized call-in. We work primarily through payers, payers who are willing to contract with us. So our doulas work in a variety of hospitals, and I saw the question about asking if doulas could work with your hospital further down on the thread. And for both of those questions, I'd encourage you to reach out to me or Lorenza, Christina at accompanydoulacare.com or Lorenza at accompanydoulacare.com, and we can hope to try to address that or maybe start conversations about how your institution might start a relationship with doulas or doula program.
Great, so that answered the question from Maureen McSwiggan, who said, how do we get connected to doulas? Right, great. I want to be respectful of people's time, and I'm going to hand this back to Barbara and Audra to say goodbye. I just want to say thanks again to everyone who presented and called in.
Great. So, this is Barbara. Thanks very much. Thanks very much, Ron and Audra. Thanks on behalf of the Betsy Lehman Center and Penguin. I want to thank all of the presenters and all of you participants for just these wonderful presentations and all of the comments and engagement. So to help us plan future town halls, we'd really appreciate it if you'd complete the survey. It's on the screen. You will actually receive this this URL to your email box if you're on the distribution list for the town hall series. If you don't think you're on that list, you can, we'll keep the chat box open for a few minutes and you can just send a chat to the Betsy Lehman Center right now with your email address. So once again, thank you, and we look forward to seeing you next Tuesday, and best of luck with everything in the meantime. Thanks.